Good, whatever time of day it is, wherever you are in the world, and welcome. My name is Charles Gore, and I'm the Executive Director of the Medicines Patent Pool. And it gives me great pleasure that I'm co-chairing this with Marisol Touraine, who is the Chair of the Board of UnitAid. So I'd like to start by thanking the World Health Summit for the opportunity to hold this session, and to UnitAid and the World Health Organization for co-hosting it with us. So the subject of this session is access to medicines in low and middle income countries and the critical role that plays in achieving universal health coverage. So this is not a session about COVID-19, but clearly COVID-19 is going to have some impact on this, potentially slowing down a lot of the health services across the world. But at the same time, COVID-19 may also be providing us with lessons about how we can speed things up, do things better, do things in new ways. So access to medicines is a big subject. And there are clearly many challenges to delivering on it. Price is obviously one, but it's certainly not the only one. But it's clearly important if you have countries that are spending 2/3 of their whole health budget on medicines. And obviously, voluntary licensing is one of the ways potentially of addressing that challenge. But as I say, there are others. It's very important that after the innovation that has produced new drugs in the first place, we may need innovation to make them more appropriate for low and middle income settings. And clearly one of the other issues that's very important is the time lag. How quickly can we make sure that there is access in these countries? And that can be the barriers there can be many, including things like registration, and perhaps COVID will help us there with looking at faster ways to make the registration process simpler. And of course, health systems. There's no point having great new medicines if the health systems are not able to deliver it. There are not enough doctors, there are not the right diagnostic tests, whatever. And maybe one of the lessons of COVID is going to be that health can no longer be looked at as a cost. And of course, if you look at it as a cost, your immediate reaction is let's try and lower the cost of something. But we need to look at it as an investment. And I think COVID is really showing the importance of doing that. And clearly, if countries are only committing 2 to 3% of their GDP to health, it's just simply not enough. But it's not just countries, it's all of us. There are many actors involved in ensuring that access happens. And that's why I'm so delighted to have this very distinguished panel today coming from a variety of different viewpoints. Because I think that unless we all do this together, we won't have access. And if we don't have access to affordable medicines in low and middle income countries, frankly, universal health coverage is just going to be a pipe dream. So with that, I'll hand over to my co-chair, Marisol Touraine. Marisol.
Hello to everybody, and good morning, Charles. And I'm very happy to be with all of you. It's a pleasure to be with you for this session. And I want to thank you very much, Charles, for organizing this session. It's, of course, a pleasure to be with the MPP. We have a long tradition of working together, and I hope we're going to do that a long time ahead. I want to say a virtual hello to our public and really express my regrets that the pandemic prevents us from meeting physically in Berlin, because Zoom meetings have some limits and don't replace the pleasure of direct conversation and discussion. Still, we are happy to be together this morning, and to jump immediately into our discussion, I would like to highlight 2 points. The first one is that access remains the key issue for global health from my point of view. And the second point is that because of COVID-19, but of course beyond COVID-19, as you were saying, Charles, we need to transform the question of equitable access into a political agenda and promote the idea that access is not only a question of technicalities, of technical approach, but it's a question of political commitment. So very, very quickly, a few remarks about those two elements. Equitable access remains the key issue, of course, for low and middle income countries, but not only. You were talking about innovation, Charles, a moment ago, and we know that the price of innovative treatments is very high, even for rich countries. It's a different approach we will have to implement, but we know the problem already exists. When we talk about access, we think about access to essential medicines. But as you were saying, real access means access to trained health professionals, access to appropriate healthcare equipment, and to organized, as well organized as possible health systems. Still, without access to essential medicines, universal healthcare will remain a mirage, and it's not necessary to talk about UHC all day long if you are not able to enhance an effective access to essential medicines. So we know there are many barriers along the road to access. Price is, of course, a major one. We should also talk about production capacity, and we're going to talk about production capacity during this crisis very much. And in some countries, legal and regulatory issues are a real problem. But, and I want to insist on that point, we know how to lower these barriers. We have done that at the MPP and UNITED together. And the story of what UNITED and the MPP have achieved to facilitate access to treatments in particular, but not only against HIV, is spectacular. So we have, I mean, just an example, because you all know, as the panelists know about that, but the public doesn't necessarily. For instance, an HIV treatment is available for $75 a year instead in Africa, instead of $10,000 a year in Europe. And that's very real. Cervical cancer test and treatment for less than $2 in Africa. It is very concrete. And that's what we have done. It's a success. It's not enough. But of course, we can be proud of what UNITED and the MPP have achieved. And so we know how to address those issues. We will have to address those technical questions. But, and that's my second point, very quickly, we don't have to consider equitable access as a technical challenge, but as a political one. And what we need is to have the leaders of rich countries to commit themselves to facilitate access, have exactly the same way as they have committed themselves to fund research, treatments, and vaccines against or for COVID-19. So if we want to convince those leaders, we have to explain and explain again that it is their own interest to facilitate global access to treatments, because if some part of the world is ill and is sick, our population, the population of rich countries, won't be able to be safe and secure. So my recommendation is to push the political idea that we have to consider essential medicines as public goods. It's not easy, but it's necessary. And the second point, we need to convince, as we have already done in the past, we need to convince the industry that it's our common interest to lower the price of essential medicines. I'm pretty convinced that we will be able to engage in discussions with the industry and to act together. I'm personally convinced that we can play together. We have done it in the past for HIV, TB, malaria. We have to be able to do it again, to redo it, to do it again for COVID-19, of course, but also for all innovation, for all innovative treatments. And that's very important. I refuse the idea that we should be fighting against the industry. We have to work together, and we will be able to do it because it's the interest of the industry. What would it mean to have great innovative treatments if nobody is able to pay for them? So I really hope we will be able to create this political momentum, and that with the MPP and UNITED and other organizations, we all be at the rendezvous of international solidarity. And I want really to conclude with where I started. UHC is meaningless without equitable access. Thank you for your attention. Thank you, Charles. Over to you.
Thank you very much indeed, Marisol, and your points are very well made, particularly about the importance of the political will behind this. Absolutely. So now it gives me great pleasure to introduce Dr. Mariangela Simao, who is the Assistant Director General for Access to Medicines and Health Products at WHO. Mariangela.
Thank you. Thank you. Thank you so much, Charles, for inviting, and thank you, Marisol, for the very, very inspiring words. And it's music to my ears because I worked 30 years in the Brazilian health system before joining the UN. And I always start any conversation on access saying that access to safe, efficacious, quality, and affordable medicines is a political choice. We, the health professionals, we very much don't like the politics of, we think that doing enough on the technical side is enough. It's not enough. You need to have the political choices that are informed by good policies, that are informed by evidence and by the science. But at the same time, you need to move politically as the health sector to make sure that these policies actually go in the direction of the interest of public health. So it's really good to hear that. And the fact is that in the last 100 years, maybe a little bit more, we know that some people will be cured of some diseases if they have access to the technologies they need. Some people will live long lives with chronic conditions, be them infectious diseases or what we call non-communicable diseases. They can live long and healthy lives if they have access to the technologies that make them healthy and productive to society, right? So this is what we see, unfortunately, in many countries where people don't have access to essential medicines, and there are many reasons for that. And Thomas will have heard me because we were on a panel together, I think in 2018 on cancer. And at the time I cited an article in The Guardian that had the headline was, "Why should the poor die young?" Okay, and it was an article about the different health outcomes in cancer patients. This was in 2018. And that question plagues me, in my whole life, my whole public health career. Why should people have different health outcomes because of where they are born or their socioeconomic conditions? And on this article, there was the issue, for example, on childhood survival, which could be up to 80% cancer survival in high-income countries and as low as 20% in low-income countries. Why would that? Huh? Breast cancer, we estimate, WHO estimates around close to 2 million cases a year. 5-year survival is more than 80% in Sweden and less than 12% in the Gambia. And there you go. And then you have the access to controlled medicines, pain medicines. Most of them are not protected by patent or anything. And we have estimations that half of the people who died of cancer every year die in pain. right? And out of these, 80% live in low and income countries. And I'm saying this because addressing inequalities is so complex because of all the structural problems, right? The factors, poverty and income and so on, that most people in the health sector don't think they can do much to address inequalities. But when you look at it from the health sector perspective, the inequities in health are fundamentally actionable. And that's where universal health coverage comes in, because there's a lot that the health sector can do to decrease the inequalities in health outcomes, for example, right? By doing the right health policies and ensuring there's funding for that. We know, for example, 90% of the global population pays for medicines through out-of-pocket expenditures. And medicines are the second largest expenditure beyond, after food. So so you fight inequities in health, and universal health coverage is an important strategy to do that. And then we had the issue of the efficacy and the fact that some medicines are more important than others. And these medicines that are more important than others, they should be available for those who need them. And of course, I'm talking about the essential medicines list, right? Because there is a growing certainty that no public sector or health insurance system can afford to supply or reimburse every available medicine or health technology that comes into the market, right? So we need systems to facilitate selection, and the essential medicines list is a global system that can help that. Of course, everybody on this panel knows that high-cost therapies have become a concern of many countries. And then there is the fact also that not every so-called innovation actually brings health benefits. The WHO's essential medicines list working group on cancer medicines noted that 2 years ago that close to 75% of the drugs approved in the last 15 to 20 years lacked evidence of substantial clinical benefit for patients at registration, right? By changing the endpoint from survival, 5-year survival, to time without disease progression, which is a much softer endpoint, you make it difficult to assess how much benefit it will go. So, but it's, you see many articles in the literature and also in WHO publications that the prices of new and innovative medicines do not necessarily have a relationship to increase in benefits provided to patients. And I think addressing also what Marisol has mentioned, with working with industry, we need to find a balance to what is a sustainable return on investment for innovation, right? Price has become a major concern of high-income countries in recent years. And last year we had the long negotiation for a transparency resolution at the World Health Assembly for markets, where it didn't go as far as to say that there should be transparency in the costs of R&D, but it moved a lot on the transparency on price. And WHO then works on the fair pricing forum, and we have been working we just launched a new pricing guideline. And the fact is the prices, even for non-patent medicines, vary enormously from country to country. So we have countries that pay more at the pharmacy than, for example, the US, which is to say a lot, right? Because prices in the US are considerably higher. A third point is availability. And then I would say you have on the availability, you have the regulatory side, but I'm not going to touch on the regulatory side, but there's a lot to say about the procurement systems, right? Because fragile procurement systems in many developing countries end up creating the environment for substandard and falsified products to be in the market. And countries with limited purchasing power, especially smaller countries, many times pay more than they should including for non-patent medicines. So this is we do see that far too often that the, the, the lack of access leads to unnecessary deaths. Pool procurement initiatives, we have some in the world. We have the PAHO procurement, we have the Caribbean. We just launched in the Afro region, the small island development states, launched a pool procurement initiative. This could be in long term, it can improve price stability, minimize the challenges of fluctuating currencies and other financial risks. And it can also pull volume and ensure more quality assurance in the product. So there, the procurement part is it's a very important part on the availability. But then besides the efficient procurement, you also need to have generics available, because competition is good for health. And this brings us to the discussion on the intellectual property rights and public health interests. IP barriers have to be addressed in the context of new medicines. There was a discussion very recent, last week or the week before, at the TRIPS Council, a proposal by South Africa and India on a waiver during the COVID time, but the WHO also has a strategy on innovation, public health, and intellectual property. WHO has an access roadmap and so on. And then we have, for example, next year it's going to be 100 years of insulin in the market. You know that, it's 100th anniversary. And you have insulin, human insulin and analogs. And still we don't have a balance. We have 3 companies that kind of do the 96% of the manufacturing in the world. Recently, WHO has done an insulin workshop and has announced the pre-qualification on human insulin. And this is to say that most of the, I think that's, we're talking about IP, but let me say that most of the barriers that are for the bread and butter medicines, for the most prevalent diseases, are not available because of IP barriers. They are not available because of everything else I said before today. Because we're talking high cost medicines, new medicines, IP barriers may be present. Hypertension medicines, the vast majority of the medicines that are still used, I graduated from medical school 40 years ago, and I see, for example, for epilepsy, it's the basic staple medicines are still the same as when I graduated, but they are still not available. Final word, I think we need to learn what happened to HIV. I see that lots of people here come from the HIV. I worked with HIV a long time in my life. It was the demand creation part of HIV, where we have not what we used to call the AIDS activists, were not just the civil society organizations. The health workers got engaged as well in the push for the increase of generic availability, the push politically for the agenda to be discussed in parliaments, congresses, and that led at the end of the day to the creation of the Global Fund and UNITAID and PEPFAR and other initiatives, and led concretely put the generic availability at the forefront of the discussion. So bottom line, I'm sorry if I took too long. WHO constitutions envisages a world in which all people attain the highest possible standard of health and well-being, and that's not possible if people do not have access to the technologies that they need, when they need it, at the right level of care, and that they should not suffer financial hardship because of this. Thank you very much.
Thank you very much indeed, Mariangela, for a very nice overview, I should say. And one thing in particular just jumped at me when you said inequities are actionable. And I think that's an incredibly important point. So now I will hand over to Philippe Duneton, who's the newly appointed, congratulations, Philippe, Executive Director of UNITAID. Philippe. think you're on mute, Philippe.
Sorry, can you hear me now?
Yes, thank you.
Thank you. I tried to pull up my slides, but seems that it's not working as expected. Anyway, I can do this without any slides. Thanks for the invitation, and thanks for the very comprehensive way to introduce this panel from Marisol and Mariangela. I think that we, of course, should remember that at the beginning, UNITED and the medicine patent pool were political ideas from member states. Of course, the founders, Brazil, France, Chile, Norway, UK, South Korea, and others, with the support of Gates Foundation. But and the MPP was coming from the NGO perspective. So just turning to, of course, how does it work? And I think that, again, sorry for the slides, but we need to understand that one of the issues is how to understand the needs at the country level, in the downstream, and how to connect with innovation with the upstream. So the breakdown is the value chain from the R&D to what the introduction at country level means. So it means, of course, clinical trials, operational research, guidelines, registration by pre-qualification at country level, demand creation, introduction and scale up. This is basically the breakdown of the value chain. And there is a very key role that MPP is playing and will play in a way that it's not just to contract, it's not just a deal between originators with generic, but is also the outcome. Medicine patent pool allows to have different type of product put together, and this has been key for the fight against HIV/AIDS. And in fact, it's the 3-in-1 thing. One pill a day makes a lot of difference for a lot of people across the world. And it was possible due to the medicine patent pool agreement with the companies. Another example is the fact that we can work on pediatric formulation that has but no, let's say, market, because there is no kids in the north. But there is a lot of kids that need that kind of medicine, in particular for HIV in the south, and agreement with medicine patent pool allows that. Now, of course, we have all in mind how innovation is important, but what means innovation? Basically, you can have 3 pillars to think about innovation. And what does it change? And I will use the example of dolutegravir that we have been working together, not only with the medicine patent pool, but also with industry, with medicine, with the WHO, Global Fund, and PEPFAR in countries. So thinking about innovation is about simplification. It's about acceleration, it's about transformation. And in all the 3 buckets, the work that we have been doing with the medicine patent pool and others has made a difference. First, dolutegravir, as you know, is the new antivirals against HIV. And of course, there is a potency that we demonstrate with clinical trials in terms of reduce rapidly the viral load for the people in need. And of course, to have 3-in-1, because it's dolutegravir with other medicine, had made more simple. And when we have been discussing with ViiV, the pharmaceutical company, the objective, it has taken a little bit of time with UNITED, ViiV, and medicine patent pool, but at the end of the day, it was before the registration in the US and Europe. ViiV has recently come together and make a deal with us. That's trigger all the energy and the partnership with a goal in terms of acceleration to say, let's reach the African continent less than 3 years compared to 12 years for the present version of ARVs, compared to registration in US and Europe. So acceleration from 12 years to 3 years. And we did it with all the good work that we have been doing with all the partnership. And of course, in terms of transformation, just the savings from now less than $65 for treatment per patient and per year, we can put 5 million people in addition, and just because of the savings is more than 3,000 US dollar a year in savings. And of course, the system benefit from that. So just as an illustration, I would the example I've taken shows, of course, how this implication of MPP at the beginning with the construction, the partnership is how United is working. I have many examples. Yesterday with Charles, we were at a panel for pediatrics. And again, there is a vast effort, but there is a vast recognition of the role that we have been playing, United and MPP and WHO together with others, to make a difference that is every day something that is key for people in need. So I will stop there. Again, thanks for this panel. I think that we should look at it also with the work that we are doing in ACTA, because at the end of the day is to find solution and close deals. And we need to be comprehensive. We need to be specific. We need to work with member states, understand what they are looking for, and find solution with industry and partner to make it happen. Thanks, and over to you, Charles.
Thank you very much indeed, Philippe, and very nice example there. And I think your points are very well made. So now I'd like to introduce Thomas Quaney, who's the Director General of the International Federation of Pharmaceutical Manufacturers and Associations. Thomas, over to you.
Thank you very much, Charles. I have to admit I was a little bit nervous before this panel because so many powerful women, so many people and one lonely industry person. I already feel a bit more comfortable because I've heard many times, I think, the notion of partnership, we need to work together. And as Mariangela knows from quite a number of conversations we have had in Geneva, and elsewhere, I feel passionate that actually one of the roles of IFPMA, the representative body of the innovative industry, is really to make things happen. And Philip just referred to WEAF. Of course, if you don't know WEAF, it is a partnership which was born by GSK, Pfizer, and Shionogi, pooling their resources in HIV/AIDS. And when we look at the progress made on HIV/AIDS, it is thanks to the innovation and the willingness of the industry. I think the industry in the last 20 years has adapted its modus operandi on many of these public health challenges a lot, not just in the area of HIV/AIDS, but also in collaboration on medicines for malaria venture, but also on TB with multi-drug resistant. And Philip and I and Mariangela, we sit quite often on ACT-A partnership meetings. We sit on COVAX. And when I look at how the industry has responded to COVID-19, we see something which Marisol Turén mentioned at the beginning. Innovation is meaningless if you don't have access. And we really, I have to admit, I'm too much of an economist to immediately agree to the notion of public good, because public good is something which is non-rivalrous and non-excludable. That is clean air, although many people in many cities in the world don't have the benefit of clean air. But medicines are not really the non-rivalrous, non-excludable, and we see it in the challenge to provide equitable access to COVID-19 vaccines. I firmly believe, and have said so many times, that if we really want to make progress, and that's why I would be interested to touch base once with Marisol Touraine, either in Paris or Geneva, when we can travel again, to talk about, we should not really fight each other. We should work together and co-create. And one of my firm beliefs is co-creation needs to be based on a social contract. Rousseau spent a lot of his life in Switzerland. I do believe that the notion of social contract has many meanings. And it does mean that, for example, governments need to play their role. We need to address issues such as domestic resource mobilization. When I look at the Abuja Declaration 2001 objectives of 15% of national budget spent on healthcare, I think even now it's less than a handful of countries in Africa. I also believe in UHC, for example, not just in terms of addressing the problem of co-pay, because co-pay is a major hurdle. And even if you could get a medicine for 50 cents a day, it might be too much for somebody who lives on $2 a day. Therefore, UHC needs to play a role, but it also can play a role, for example, in terms of establishing national formularies, making sure that people get quality medicines. I recently was able to convince industry leaders to set up a $1 billion fund for research in novel antibiotics. Problem in many African countries is people don't have access to mature generic antibiotics, which cost almost nothing. And they quite often get access to fake medicines. Therefore, I think we really need to work together. And I'm the first one to say that clearly, social contract needs to imply that we need tiered pricing. Rich countries must be prepared to pay more for medicines or vaccines than poor countries. We have been a partner of Gavi for 20 years since the beginning. Gavi shows how much you can do. You also see the same, by the way, with the Global Fund. But one of the challenges, and that's why UHC and domestic resource mobilization is important. My friend Joseph Kibacho from Kenya, when he moved from the NCD role into the bigger role, he told me in one day he had a bigger budget to spend than before he had on NCDs. Therefore, I do not expect, I'm a realist in terms of global politics, and we see the challenges of fundraising right now with Act A, Philip and others. I do not expect that we will get the global fund for NCDs. Therefore, we really need to address, on the one hand, the domestic resource mobilization, and on the other hand, we also need to work on how can we get better models of tiered pricing? How can we work on health systems resilience? Now, since the hosts here are the medicines patent pool, as Charles knows, I think one of the elements when you look in HIV/AIDS is that companies have been willing to voluntarily sign licenses with the medicines patent pool on HIV/AIDS drugs. We have from IFPMA endorsed the expansion of the scope of the mandate for the medicines patent pool on cancer as well as on COVID-19. I think one of the important elements is the voluntary nature. I've told Marie-Paul Kieni a couple of times that means she needs to apply her charm to convince the companies that it makes sense to work together. I believe that companies are really concerned to improve access, but they're also deeply aware that access is multidimensional. To give you just one example, I was heartened yesterday when I heard John Nkengasong, one of my COVID-19 heroes, make a strong and passionate pitch for the African Medicines Agency. The reality right now is it takes up to 4 years to get a formulation change approved across Africa for a vaccine. You imagine what kind of problem that can be. Mariangela referred at the beginning, we will have the centennial of insulin next year. Now, I'm fully aware of, let's say, the challenges of insulin, and I occasionally tease my US colleagues that there are two really big problems. One may be in Africa, where people have struggled to pay for insulin, and the other one is in the US, where patients pay more out of pocket than the manufacturer gets for the insulin. And this is honestly a situation which is not good. But the issue is when you look at the diabetes treatment, and Mariangela referred to the recent workshop, fact of the matter is that test strips are quite often not available, or they are too costly, that glucose meters are not available. And one of the anecdotes, which I think is a really sad one of the member companies, one of those 3, had a program for insulin for free diabetes care in Kenya, and they had a patient who had significantly improved, didn't show up at the center where he was given the insulin for 4 weeks. When he finally came in a bad shape, they asked him, "Why didn't you come?" He said, "I didn't have the money for the bus ticket." There you see, the multiple challenges we are confronted. I truly believe, and I see companies are moving, they're moving actually from CSR to sustainable business model. Sustainable business model must include a willingness of offering tiered pricing. It must include a willingness to do co-creation. What I see in ACT-A in COVID-19 right now, I would really call co-creation of the best. We are still facing multiple challenges, but I really look forward to working with you, talking with you, to make sure that we are moving forward, because I do believe, and I will leave that for the next question round, IP is not a barrier. IP is an enabler. Most of the generic medicines, which are so important on the essential medicine list, have originally been created by innovators. They are now very cheap by generics. Therefore, IP also in terms of fast response to COVID-19 has enabled us to react fast, but we must make sure that IP is not the barrier to access. We must work together to improve access. Back to you, Charles.
Thank you very much indeed, Thomas. And I particularly like your point, with which I totally agree, the importance of making sure that access is part of the business model, not part of just CSR. So I'd now like to hand over to Graham Cook, who is Professor of Infectious Diseases at Imperial College, but also chair of the expert committee, the WHO expert committee on the selection and use of essential medicines. Graham, over to you.
Thank you, Charles, and thank you for the invitation to talk today, and perhaps what might be the longest title I've ever been given to talk to. So thank you for that. I'm going to make a few comments about the EML. I'm assuming that most people are familiar with it, but this is a long-standing product of the WHO since 1977, and it was last updated in 2019, and now lists about 460 medicines within it. And the prioritization for this inclusion is really based on high quality evidence of efficacy and safety. And prices of the medicine is not really the primary consideration, and I'll come back to that. But really, the EML, both at the WHO level and at a national level, sits in this ecosystem of different interventions that we have for access. And I won't go through all of these, but just to emphasize that this is just one part of the puzzle in terms of what we need to be doing to improve access. And just to give a specific example, which might be close to your heart, and I think illustrates many of the things that can be achieved around access. I think viral hepatitis shows us some good examples of what can be done, particularly hepatitis C in recent years. And we saw between 2011 and 2015 a huge amount of innovation in industry, new medicines coming through that were curative and had much better side effect profiles, but at the time were very expensive, in particular because they could be priced for the value of the health returns that they brought. But in parallel to this, I think emphasizing the point of co-production, we also saw innovation from industry with early voluntary licenses and bilateral agreements between innovators, allowing early production of generic medications in low and middle income countries, and particularly around 2 compounds, sofosbuvir and declatosphere. And so by 2015, they were listed on the EML at a time when actually the prices of those drugs were beyond the reach of many rich countries, let alone low middle income countries. And by 2017, a range of other medicines that could achieve similar outcomes for patients infected were also approved. And subsequent to that, we've seen further expansion in moves from industry for access, first through an expansion of sofosbuvir availability into middle income countries, And more recently through MPP, as you'll be aware, the approval of another combination, which is now licensed for voluntary licensing. And obviously within that, we welcome the move for the medicines patent pool to be expanding to more medicines on the essential medicine list. And so for these two particular compounds, we have seen these dramatic falls in price. And actually on the left-hand side, it says over $3,000. In fact, when we started, this particular combination in the US was over $100,000. But we've seen these very dramatic falls in price to the point where in East Africa now, the programs are paying around $60. But as we've heard already, $60 for a course of treatment is still well beyond many health economies. And so we need to go further. In some places, it's under $50 and it may yet continue to fall. But this has been a really dramatic change in the space of maybe 4 years. Our own work has shown that there's a very clear association between voluntary licenses being available to low middle income countries and treatment uptake increasing. And that seems very clear. And we are now seeing rising treatment rates. So India exported over 100,000 courses of hepatitis C treatment last year. But that's obviously still a long way to what we need to get to. You know, we think there are 70 million people infected with hepatitis C in the world. So there's a lot of progress that still needs to be made. But some countries like Egypt, for example, were able to treat over 2 million people in 2018. So things can be achieved. And as we've heard already, you know, political will and finance is critical to that in different parts of the world. So within the essential medicines list, in recent years, we've had three sort of bigger strategic efforts. One has been around definition of essential antibiotics and the creation of the AWARE classification, which I won't go into, but that's a tool for stewardship of antibiotics, which is now adopted by the G20, and it has a target set for it within WHO. Perhaps of more relevance to this conversation, prioritization of cancer therapeutics has been a recent focus, really trying to define what it is to make a cancer medicine essential. And that's led to the inclusion of a number of medicines into the essential medicines list, which are still very expensive in well-developed countries. So imatinib, trastuzumab, pembrolizumab, and other drugs like that, which are amongst some of the most expensive medicines in the world. But now cancer medicine has a much bigger part of the EML, about 12% of those drugs listed. And finally, in our recent iteration, we included a number of monoclonal antibodies and their equivalents, particularly anti-TNF antibodies, which is obviously an important area of medicine where inequality is still very high. So in doing this, the committee recognized that these medicines are associated with a significant budget impact, but because they're used for long periods and they're often highly priced. So they are good examples of where inequality persists in access to highly effective new medicines. And I won't go through this in detail, but for those interested, the Wellcome Trust have just produced a very useful report on access to monoclonals. And this illustrates how in richer countries with national reimbursement, many of these are available free to the point of care, whereas in low middle income countries, hardly any of these are available, and there's a huge disparity. And in relation to COVID, you said this wasn't about COVID, but actually this could be about COVID. I mean, I think we're starting to see a shift from our thinking about what might be a useful antiviral from a small molecule like remdesivir. And you can see when I made this slide, I was still hoping I might be in Berlin, to more recently where actually the most promising antiviral might be a monoclonal therapy, even though we don't have good randomized controlled data on that. We need to be thinking about what happens if that does show a good effect and how are we going to help that become available, even in well-off countries where it's going to be difficult to scale up, but certainly we need to be thinking about it at a global level. So just to conclude, I mean, there are clearly critical gaps between what happens in listing on the essential medicine list and achieving widespread access. But certainly within the EML, there's a welcoming of the move from the Medicine Patent Board to expand its remit across essential medicines. And I think there are really good examples of good progress, particularly with small molecules that can show us what can be achieved, although clearly more needs to be done. But there are clearly areas like biologics where we need greater efforts to narrow the gap. Thank you.
Thank you very much indeed, Graham. That was great. And yes, certainly in the biologics and the biosimilars, that's an area that, yes, definitely needs more work. So now I'd like to hand over to Maureen Marenga. A couple of the speakers have mentioned Kenya so far, and in fact, Maureen is in Kenya. She's the executive director of Lean On Me, an NGO working with women and adolescents in and providing support for HIV. Maureen, over to you.
Thank you very much, and it's really quite an insightful topic. I'll give it an approach of a person who is a recipient of service or someone from the community. And I can say that in Kenya, we have political goodwill for UHC. On the 12th December 2018, President Uhuru Kenyatta declared universal health coverage to be a national priority in Kenya as part of his Big Four agenda for national sustainable development. Under this initiative, the government committed to make strategic investments in health to ensure that all residents of Kenya can access essential services. We also have a very progressive constitution in Kenya where there's an overarching legal framework for right-based approach to health. Ideally, we can say that UHC is a beautiful concept, but we have had challenges as a country. One, because our health system is devolved, and therefore health services are provided at the county level, or what some people call district level. And you find that there are some counties that are more proactive, that have a good allocation for health, yet others have very little allocation. We go from maybe 30% allocation to health to others giving 3% of their allocation to health. So the quality of health services differ in different countries, in different counties of this country. What is common is that most of us have to pay out of pocket for health services, which has implications on willingness of most patients to take services or seek care, particularly for what is perceived to be more complex issues such as cancers and other non-communicable diseases. You find that it is easy for someone to go over the counter and procure a medication, because if I had malaria today, I would be charged like around 150 to 300 shillings. That's about $1 to $3 for the diagnosis. And then after that, I'll have to buy the medication. And sometimes that is too much for families that are struggling, which are the most common families. And therefore they opt to self-diagnose and do over-the-counter medication, and then sometimes also leading to especially resistance to antibiotics. And then another challenge we have is that most of our health budgets are donor dependent, especially for major epidemics such as HIV, TB, malaria, and COVID-19. And so people seeking those services are able to get some form of good quality services because it's donor funded. But in case someone gets other opportunistic infections or non-communicable diseases, then they have to go out of pocket. And therefore, sometimes we say that whatever kills us is not what is being treated, but what we are missing. We also have the issue around privatization of health services, and you find that most good quality health service is found in private hospitals, which are expensive. And for public hospitals, we have the National Health Insurance Fund that is, it's a comme ci comme ça. It's neither here nor there, because sometimes you have paid for your health insurance, and most people can access services through the public hospitals, but you find that either doctors are on strike or we don't have medicines in hospital, and therefore it hasn't become quite a solution like we envisaged it would be, the vehicle that would lead us to universal health coverage. And sometimes also it's not trusted when you are paying insurance, but you don't trust that you will get services out of that insurance cover, then it really takes a low uptake. We also have very poorly funded primary healthcare systems where either the doctor is overburdened or the nurse is overburdened, or there are no medications, or the hospital has a lot of infrastructure issues. And this also has really compounded on access to health services, especially from people of the lower quintile. And we know that this is actually universal health coverage is something that is doable, and there's a lot of, there's need to be a lot of partnerships, collaborations to be able to achieve this. Countries need to raise sufficient revenue for the health systems. Kenya had committed to the 15% Abuja declaration. We didn't do that. we committed also to giving 5% of our GNP to health. We are only doing 2%. So some of those things that are doable are the commitments that our countries sign. Sometimes they don't meet them, and therefore the reason why we are leaving quite a big population unable to access health services. And then the other one is about creating efficiencies and adopting innovation. There's a way that if services are integrated, it saves a lot and we are able to reach more people, but that is not happening to scale. We are not working towards ensuring that we create efficiencies so that we reduce the burden of the cost of health for the normal citizens. And then we also need to ensure that there's a lot of imbalance between people who live in urban areas and rural areas. So you find that in the rural areas, the services are poorer, and therefore many people are dying of conditions that can be saved. And therefore creating that equity in the service delivery is also very important. And I always say that universal health services is that beautiful concept lives out a very significant populations. We still have in our countries populations that are criminalized, and therefore they are not accounted for in the public health domain. So when you have these people left out, then we are not reaching everyone, so we can't call it really UHC. So I think in my take, I would say that universal health coverage should be equitable. And another thing, it should be sustainable. I remember when they rolled it out in 4 counties in Kenya, it was funded by World Bank. And therefore it looked like a project that after a while, World Bank would stop funding and then it would end. So I think it should be something that is country owned and that it is sustainable and that the country can offer it with or without external support. And that country is able to coordinate the different avenues for resources to ensure that the basic health services are accessed by their people. So it's not just about bringing numbers to the facility that doesn't have equipment, but it should be about universal health coverage and impact, ensuring that people are accessing quality services and that we reduce deaths that are unnecessary. Thank you.
Thank you very much indeed, Maureen. You made some very good points there. And I was interested in you saying that even medicines that might be on the EML might actually not be available, or by the time they get to country, they're a large out-of-pocket expenditure, all of which need to be addressed through UHC. So thank you. So our final speaker is Jay Iyer, who is the Executive Director of the Access to Medicines Foundation. Jay.
Thank you, everyone, for the invitation and also for taking the time to join us today in this discussion. So I lead the Access to Medicine Foundation, and we've been for about 15 years in analyzing and looking at the relationship that the pharmaceutical industry has with society and the public, specifically looking at low and middle income countries. So the context of my work is looking at the 80% of the world's population that live in low and middle income countries. And that's something to keep in mind throughout the whole discussion. Now, what we've shown already in the past years is that key areas that are heavily driven by international priority setting, donor alignment, and donor support into the innovation mechanisms and market shaping mechanisms have actually been key drivers of progress that has been made so far. And that includes setting up and the development of Medicines Patent Pool and Gavi and CEPI that is now bringing us through some of the successes that we're looking at right now. I think that what we have to recognize is that there are clear differences in how each government and each company addresses access. We have seen over the years many companies also prioritizing access. The growth of access teams in many companies is also kind of developed, so it's more cross-sectional across companies. But there are, of course, certain companies and certain areas where there's not as much effort in that sense. Now, the bulk of the action that we've seen from the pipelines, for example, and activities in terms of addressing access to essential medicines have been mostly carried by a few companies. And these are, again, the same companies that step up when it comes to an urgent reaction, for example, when it comes to pandemic preparedness and things like that. So I think for us, what's a key important takeaway is that currently, while there has been progress, the scale of the solutions in order to expand access to the patients who are currently missing access right now is really not matched with the scale of the challenge that we face out there. So it can be done, but we need to think of scale. And this has been a problem that many members of the industry, many members of society have been struggling with for a long time. So there is a technical component to it, and there's definitely a political component to it, as Marisol already pointed out, that we need to also leverage. What we need is we need to acknowledge a few of the hidden problems and some of the chronic issues that are there in that relationship between industry and society. There are chronic issues in drug pricing, in how IP is managed, in how vulnerable populations in low and middle income countries and in rich countries, to be honest, are always lost in line when it comes to our initial response. So making sure that the most vulnerable populations are front and center in any of our responses is, I think, a key component to look at. There's also, of course, what we call hidden problems, bears along the road, along the way that we need to be more aware of. And this pandemic has also kind of heightened some of the attention and awareness of such issues, such as the security of active ingredients, such as the security of older drugs, where there's still very, very few manufacturers. We assume that because generics are actually available, that this is being widely produced and of top quality. It's not. A lot of different products are slowly being diluted away from society, and they're just not available anymore. And we've seen chronic shortages and stockouts in the last few months. And if you look at the shortage list over the last 10 years in many different countries, you'll see a lot of common antibiotics that are going to be there, injectables specifically for populations where they expect a potential lower volume and no market shaping that's actually available at this point. So we need to tackle the chronic problems that are there. I think a very key statistic that we've used a lot when we're working with the pharmaceutical industry and engagers in the pharmaceutical industry is a statistic from IQVIA. What they have shown is that new drugs that have been launched in the last 5 years or so are reaching about 10% of treatment eligible patients in high income countries, only 10%. When it comes to low income markets, such as some of the emerging markets, not even the least developed countries, they reach less than 1% of treatment eligible patients. And that tells you that there's an underperformance generally when it comes to thinking about how are we going to expand access almost at the get-go in that sense. So what do we need to solve this problem? Firstly, I think we need to acknowledge that we need a more diverse set of actors. So more of the companies need to kind of step up into the game. This includes actors outside of the big pharmaceutical industry. Big generics have been playing a role in taking on some of the voluntary licenses for bringing innovations to people. And we need more of them to step up. And we also need to realize that they are facing issues in terms of the absorption of manufacturing capacity and production capacity being absorbed into a few geographies, leaving other geographies chronically behind in certain issues. And that bridging of that gap is an important thing to prioritize for us. We've been doing some work with members of another industry, the medical oxygen industry. And that came also because WHO has prioritized medical oxygen as an essential medicine. And when something is put on the essential medicine to this, it gives us the legitimacy to say this is a priority. Many people have come together in saying this is a priority. So we need to do something about it. There are other examples from other essential medicines that we can work with. So what we've done is we've been working with the Every Breath Counts consortium and established a list of 10 key action areas, including identifying the oxygen gaps, recognizing that 1 in 5 COVID patients will need medical oxygen, and medical oxygen shortages has been a chronic problem for childhood pneumonia. And we brought together global health agencies and medical oxygen companies using our unique engagement model to sort of make sure that people are working on this particular issue and in the momentum of COVID-19. An area which I think we need to think about now, and I turn to solutions, is early access planning. One of the reasons why products actually don't reach people is we're not doing that thinking, we're not doing that arrangements, we're not building the relationships when a product is in development. And in the years of my own background in malaria vaccine development, many different international stakeholders came together to say, this is what we need in terms of the product attribute, but this is also what we need in terms of its ability to reach the patients who are highly burdened by a particular disease. And we don't have that for all the different areas. WHO now is working towards building more of these target product profiles. And what we need is more donors, more members who are engaging in innovation to ask for access planning to be done as early as possible. That means prioritizing registration in high need areas, looking at what affordability means before a product is actually ready on the market, and addressing supply chain issues, because we do have manufacturing capacity if we put our mind to it in that regard. The second issue I think that we can solve, because again, there are technical solutions, are better management of intellectual property. Voluntary licenses have been a mainstay and have been critical in HIV and hepatitis, and we're hoping to see that expansion into more different areas. And I think the medicines patent pool has already shown that the quality of licenses is what enables that broad access. If you don't have a good quality license in place, you will not have broad access, and the word licensing is just only in name alone in that sense. We also have seen great strides that are possible when people put their minds to it in technology transfer, in enabling the manufacturing capacity and production capacity to be broadly available in many different areas itself, and IP sharing, which has been a mainstay that's developed from the years of neglected tropical diseases, where we used to screen many different compounds, and that needs to be something there also for chronic diseases. I think the better considerations of affordability is an issue which is difficult to tackle, and we've seen some really good examples in terms of how certain enablers are trying to create price segmentation to enable different types of patients in their ability to pay, to address, to reach patients and reach products in a more innovative way. Scale is difficult at this point, and it does mean that companies need to be aware that they will have less profit margins than what is normally expected. So there are a few solutions around affordability that I think we can work a little bit stronger on in that sense and leverage that change. Lastly, I think the better security of supply. As I said, there are hidden problems associated with APIs, pharmaceutical ingredients, costs associated with the heavy dependence on a few geographies, which are then exacerbated by trade problems between countries or border closures that we have seen so far. So that security of supply needs to be addressed in some shape and form. Now, we'll be bringing out the index, the Next Access to Medicine Index in January, and there we will start showing the difference between how companies have been working together, what are good models of success, have we managed to safeguard areas that we've promised and committed progress, or have they taken a beating because of our attention moving into coronavirus or otherwise in that sense? Now, I think I'd like to close by saying, we used to celebrate when we have a product that is approved on the market. I think our chance to celebrate should be when there's local availability really at the patient level. That's something that we need to sort of end with. And we've been leveraging also investment firms, the investors who invest in the pharmaceutical industry, as there's an increased awareness in them. And they've been writing letters to the pharmaceutical companies, congratulating them on steps that they've been making, but also pushing them into saying, okay, where are we in terms of filling those gaps when it comes to access to healthcare? Thank you again.
Thank you very much indeed, Jay. Okay, so I was going to go around and ask each of you questions, but in fact we got some questions from the floor, so I think we might go immediately to them. So I'll address this first to Thomas, I think, and then Jay, you might want to comment on this, given what you just said about working with investors. So the question is, within companies, how can we ensure that sustainable business models for access become mainstreamed, rather than just for a few products, like, for example, HIV? In other words, as you were saying, Thomas, in your talk, moving it out of CSR and into the main part of a company where it gets proper attention. Thomas.
Thank you very much, Charles. And actually, the challenge within the companies of the folks who have to make the case that this is worth doing is a real one. But honestly, it's easier to do if it's a sustainable business model than if it's just CSR. Because CSR is not business. Therefore, you really always have to make a special case. Whereas when you talk about the sustainable business model, it is something which hopefully will be sustainable. I see a really movement in companies such as Johnson & Johnson, such as also Novartis, GSK, but many others, Pfizer, are moving into this. One of the elements why I believe it, if we really want to make progress in access, and I believe that the industry is committed to making, and there will be either out of our own, we reached the conclusion we need to do it, or we will be pushed towards it. There's also an element which shouldn't be underestimated. Companies have not only, bought into SDGs, they've increasingly bought into ESGs. And when I look at, for example, another example, Comcast in the US, they're very much in ESG because the broadband access in the US has huge social discriminatory impacts. Access to medicines has a huge impact in terms of the S of the ESG. And I see companies very conscious of the importance of ESGs because that's also how investors like BlackRock and others act. Therefore, I'm in principle optimistic, but we do need this social contract because selling cheap medicines at lower price to LMICs, it means they should stay and they should reach the patients for whom they are destined.
Great, thank you very much, Thomas. Jay, did you want to comment, given the work you've done around making the business case for access?
Yes, please. We've been working with about 100 investors, kind of building that like-minded community. And you have to realize about 10, 15 years ago when the foundation started, we had a group of investors and we had one or two. And initially people were looking at us thinking, this is a CSR problem. This is a problem that is not something that is going to be a mainstream. And eventually it grew purely because they started seeing risk associated with risky behavior, and eventually that grew to opportunities. And today we have all 100 of our investor community really recognizing the fact that, look, we're going to lose money everywhere. We're going to lose credibility of our shareholders and stakeholders everywhere if we don't prioritize access to healthcare. And this pharmaceutical industry is critical in that. So that increased recognition, I think, has helped a lot. Now, I think there's a few things that we've seen in the last few months, which I think we have to kind of leverage for the next years in that sense. One is, I think, several of the investment groups, for example, the Interfaith Center for Corporate Responsibility, ACMEA. There's even an op-ed that's been written by our investors and ourselves in saying that we need to support that global collaboration and solidarity, not in name, but in very specific actions that need to be done. Now, it takes a few brave investors and a few brave CEOs to make sure that that actually happens in that sense, right? And I think one of the major issues that we face is that at the end, a lot of the mainstream investors are still looking at profit margins over volumes. And it is very, very difficult to get also companies to share data and share that best practices in their experience. I mean, I have evidence that shows that when companies actually lowered their prices and focused more on increasing volumes, they ended up getting more revenues than companies who did not take that step in that sense. But that's that long-term vision that needs to be in place. But that is a very, very difficult area to convince many different companies and their investors to move on. So I think that global solidarity is critical, because once we prioritize these areas, we can, I think, make that change that needs to happen.
Great, thank you very much indeed, Jay. And just to people listening in, please do use the Q&A facility to send questions. If we have time, I'll ask them to the panel. Some of them might be better answered text. We might even answer them after the session, given that the session is running on now. We've only got about 10 minutes before we need to think about closing. So a quick question to you, Mariangela. How long are you seeing it take for medicines that are put on the essential medicines list and the last one was 2019, to actually reach countries, and more importantly, to reach people. And what are the reasons if there's a long delay in that?
Thank you, Charles. Let me just do a quick comment on the two, on Jason and Thomas. You know, because we are talking a lot about pricing and global solidarity, and I think this pandemic has brought something good. You know, and I think we should think of the long-term impact of this. We've seen things that we haven't seen before, like companies joining efforts to produce at the fastest way possible products into the market, and the cost plus approach. You know, that I think we've seen good things that should last longer than a pandemic. You know, and I think the main issue, and I very much like what Jay was talking about, the long-term vision and pricing versus volume, because there are problems with the tier pricing, as Thomas was referring to, that high-income countries should pay more. And there are problems because small markets in high-income countries who are small markets became hostages of very high prices. You know, so this pandemic also showed a different dynamic between small markets, be them lower and lower middle income, high income countries, or in big markets who can negotiate prices. So I think there's a lot that I hope will stay after this pandemic ends. And that's related to what is the investor side, Jason. What is a sustainable return in investment for an industry that is dealing with the health of billions of people, right? That's right. Now on the EML, how long does it take until it comes into the market? I think it's not so much of what's on the national EMLs, because many times more medicines are put on the national EMLs than they are, and Graham can talk a little bit about this as well, than they are on the global EML, because of different types of assessments and so on. But the factors that impact on the entry at country level, it's regulatory issues, whether the product is registered, the affordability issues, what's the price, will the government be able to procure or not, and how is the private market working with it. So we since 2017, we have been monitoring the compliance of national EMLs to the global EML, and we see a great variety. But I wouldn't say that is the major issue, unless the countries have legislation that only allows them to buy if the product is in the essential medicines list. My own country, Brazil, does that. You cannot buy a medicine through the national procurement if it's not on the EML. That's not the reality in most countries.
Great, thank you very much, Mariangela. Graham, did you want to add anything to that?
No, I think we've covered it well. Yeah, no, that's fine.
And Maureen, oh, sorry, Philippe, before I come to Maureen, you wanted to add to that?
No, I just want to strengthen the point on how access planning is key, because this is exactly the core business of United. It's not just to push the innovation to have the drugs, but also it's a country readiness, it's demand creation. And of course, this for us, as I mentioned in the case of dolutegravir, but it's also very important in the new tools of COVID-19. So just to highlight the discussion we have in therapeutic and diagnostic, and Mariangela and Thomas know that very well, that as far as we want to push the R&D, we want also to push the preparation of country with the guidelines, because we cannot expect the country to respond just only with tools, but also to have the thinking on how people will get access to test and treat. It's a basic element for, of course, deal with the pandemic and infectious disease, but it's absolutely key in that case also for COVID-19. Over to you.
Great, thank you very much. Well, actually, Philippe, while you're on, perhaps I'll just ask you one of these questions for the floor before I come to Maureen, which is, how can pharmaceutical companies and diagnostic companies be enabled and provided with more opportunities to play a more integral role in strengthening quality primary healthcare in low and middle income countries?
So I think it's the key element if you think about universal health coverage and primary healthcare. You need to have not primitive healthcare, which is in most of the location, the reality, and not primary healthcare. So of course, I think the vision is to make sure that the tools are not just available, but they can be supported. I will just take the example of cervical cancer with women's health. What we are implementing with the call for action with WHO, with CHI, with Expertise France in a lot of countries in Africa, in South America, and in Asia, is to demonstrate that test and treat is possible to offer for cervical cancer for all the women for less than $1. And I think with quality means that it's not just a nurse, a trained nurse, that can do the test and the treatment, but also it's a network with quality. So it's more, the efficiency is better with the test, with HPLV. It will be even better with artificial intelligence. So it's a case where we can use the innovation to enhance the capacity of response from the health workers to increase access to quality services, and also in one go, because what we are pushing is that the same day the woman can have access to tests, and in case there is a lesion, they can have access to thermoablation, for example. So again, we have many examples like that, but the thinking in advance to say, what can we change with innovation is key for the response. Over to you.
Great, thank you very much, Philippe. So Maureen, can I turn to you? You know, you are somebody living in a low middle income country, someone living with a chronic disease, HIV. What are some of the frustrations and opportunities you've seen in access to treatments over the last decade? Because ultimately, this is what it's about. It's about people and their experience of this and what they need all of us to be doing to ensure that they can get access. Maureen.
Thank you very much. When I was first diagnosed with HIV, we didn't have treatment in Kenya. So we used to be given, we could go for anything, concoction. If you boiled grass and you told me that would cure HIV, we would go for that. We took our urine in the morning because we were told that was also a cure. So we tried anything just to live by then. And then later we heard from our peers from Europe and other parts of the world that they had what they called ARVs. And we were dying to have these drugs come to our country. So we had a lot of advocacy going on. We had a lot of lobbying. And finally, we had organizations. We had a few medicines coming to the country. They were too expensive. Some of us did not even hope to get them because they costed more than what we earned. So later, when Global Fund and PEPFAR came, and now we could get generic medicines, it was also on people being given to people who are dying. It is very frustrating to know that you're dying and some medication can help you. It is available in another part of the world, but you cannot get it. So that is the situation where we are in. It's a very hopeless situation. And then came the drugs, and they had very adverse side effects, and people developed conditions such as lipodystrophy. And but you know, we were told that you just have to take them if you want to be alive. So we had a choice between taking the drug to develop another condition that would still kill you, or staying without it and dying faster. So it was quite also a very big, a very difficult place to be in. And so far we have seen better drugs coming to our region. They come in a bit late, and especially I'm not the only one who had HIV in my family. My son, I had a son who was also HIV positive. It was difficult to get medication for him initially. So I got my adult formulation, but there was nothing for my baby. I could not take medicine and watch my child die. So I would break my medication into half and give him. But sometimes one half would be bigger than the other, and you're like, so what do I do in this instance? But anyway, it was just by taking chances. So I can say times have improved. We are able to access treatment, but it's not everyone is able to access treatment. And secondly, we are still struggling with pediatric formulations for children. And I know this is one area where a few people are interested in, but I think for countries like Kenya, where we still have high mother-to-child transmission of HIV, it is still very, very important that we get pediatric formulations for children. So those are some of the formulations, and these have been compounded now by people who are aging with HIV and having other non-communicable diseases. You find that ARVs are funded for, but you cannot treat if you have diabetes or you have cancer. That is very common. Cervical cancer is common with women living with HIV, but when you get cancer, it becomes a death sentence again, because we go back to not being able to access treatment if you're not rich enough to travel to India, or if your family cannot afford to take you to a big private hospital. So I think we are still not yet there. Thank you.
Great. Thank you very much, Maureen. Well, we've come to the end. Still quite a few questions from the floor. We'll endeavor to answer those separately by text. Thank you very much indeed to our panel. I was going to do a summing up, but actually we covered so much in this very interesting discussion that I'm not even going to attempt to do that. I think this nice little phrase that I've noticed the ACT Accelerator started using now, that whether you live shouldn't depend on where you live, really sums it up about the importance of access. So just finally, before I hand over to Marisol to say a few final words, I'd just like to once again thank the World Health Summit, UNITAID and WHO. And as I said, all my panelists, thank you very much indeed. You were wonderful. Marisol.
Thank you, Charles. I want to thank all our panelists also, because it was extremely challenging and constructive. I think the discussion was very interesting, and we would like to go on and be able to produce new ideas. I see there is a common will to go further and to consider that access is both a question of access to products and to innovation and to health organizations and professionals. And we have to address this question of access both from a technical perspective and from a social and a UHC perspective. I want to say that, as Philippe recalled it, UNITAID was born as a political idea, and we have achieved great successes with the MPP. And the question today is to know whether we want to expand those successes, or if we accept, as some leaders and companies seem to wish, or if we accept to stick to the original idea and not to go beyond the scope of the three pandemias, HIV, TB, and malaria. And that's a main issue for all of us. And that's what public good discussion, the discussion about public goods means. And the second point I heard during the discussion, which was extremely interesting, is that when we facilitate access to products, we can also facilitate the organization of the health systems. That's what United does. That's what other organization does. And we don't have to oppose the question of products to the question of health services. We have to address both issues at the same time and with the same responses. I don't have time to develop that. Philippe gave very precise examples, interesting examples, but I think we have a lot to work on and a lot to discuss together. And so thank you to all of our panelists, and thank you to you, Charles, for this nice invitation.
Thank you very much, Marisol. Thank you all, and thank you very much for our participants. Goodbye. Have a good day.
Thanks a lot. Goodbye.